Slow-release creatine products position themselves as a refinement of standard supplementation, delivering creatine in a sustained, gradual release rather than the spike produced by dissolving powder. The pharmacokinetic rationale is familiar from drug delivery. Sustained release formulations maintain more stable blood concentrations, avoiding peaks and troughs. In drugs, this can reduce side effects and improve therapeutic consistency. The problem with applying this logic to creatine is that the pharmacokinetic outcome that matters, blood creatine concentration, is not the primary mechanism of creatine's ergogenic effect. What matters is muscle creatine accumulation over days and weeks, not the shape of any individual dose's blood concentration curve. Blood creatine peaks after supplementation and then returns to baseline within a few hours. This kinetic profile does not affect how much creatine ultimately loads into muscle, because the creatine transporter in muscle is not operating near saturation at any point during normal single-dose supplementation. The transporter can handle the intake during the period when blood creatine is elevated. Whether that elevation is a narrow peak or a broad sustained release does not change the total creatine taken up over the day, assuming total dose is equal. The specific slow-release mechanisms used in commercial products vary. Some use polymer matrices that trap creatine and release it as the matrix degrades in the gut. Others use modified tablet coatings that dissolve progressively. Some use effervescent systems that extend the dissolution curve. None of these delivery systems have demonstrated meaningfully superior muscle creatine loading in rigorous head-to-head trials against standard monohydrate. The gastrointestinal side effect argument occasionally appears in slow-release marketing. The claim is that releasing creatine more gradually in the gut reduces osmotic effects and the bloating or discomfort sometimes associated with large doses. This is mechanistically plausible. Large osmotic loads entering the small intestine rapidly can cause discomfort, but at standard maintenance doses of 3 to 5 grams, this effect is minimal for most people. The GI comfort argument for slow release is primarily relevant to loading protocols, where doses of 20 to 25 grams per day might produce discomfort in sensitive individuals. For someone not doing a loading protocol, which is the approach most supported by evidence for long-term supplementation, slow-release creatine addresses a problem that does not substantially exist at maintenance doses. The cost premium is not justified by the mechanism, and the clinical evidence for superior outcomes is absent. Standard monohydrate powder, dissolved and consumed, remains the evidence-backed default. The drug delivery rationale for slow release is worth examining in the creatine context more carefully. Extended release formulations in pharmaceuticals are designed primarily for drugs where the peak blood concentration causes toxicity or side effects that the therapeutic window requires avoiding, or where the drug's therapeutic window is narrow enough that constant blood levels are necessary to maintain efficacy without toxicity. Neither condition applies to creatine. Creatine has a very wide therapeutic window. Doses ranging from 3 to 25 grams per day have been used safely in research. Peak blood concentration after a single dose does not cause the kind of dose-dependent side effects that motivate extended-release drug design. The therapeutic effect, muscle creatine loading, occurs over days and weeks through a transporter-mediated process that is not meaningfully affected by whether any given dose's blood concentration curve is narrow or broad. The effervescent format is sometimes marketed with slow-release language but is actually the opposite. It speeds dissolution and presentation to the gut. The effervescence helps mix the creatine thoroughly, reducing undissolved particulate. This is a practical improvement in delivery, not a slow-release mechanism. The conflation of effervescent with slow release in some marketing is a separate mischaracterization. What slow release might genuinely offer is reduced osmotic load in the proximal small intestine at any given time. Creatine is an osmotically active compound. It draws water into the gut lumen as it dissolves. At high loading doses, the osmotic effect is sufficient to cause loose stools or bloating in sensitive individuals. Slowing the release could theoretically spread this osmotic effect over a longer intestinal segment and time window, reducing peak osmotic concentration. The evidence that this theoretical benefit materializes in practice at maintenance doses remains absent.